Welcome to another segment of the Greater Detroit Agency for the Blind and Visually Impaired's Education Series, where we discuss eye health, vision preservation, and issues affecting individuals within the disabled community. Our segment will begin shortly. Please remember that the information shared in this presentation is meant for educational purposes only. It is not to be construed as medical advice. Please consult your healthcare professional for guidance regarding your own medical care. Good morning. We are happy to be joined today in a conversation about sickle cell retinopathy with Dr. Pradeepa Yoganathan. Got that right. Just a little background. Pradeepa Yoganathan is an associate professor at the Kresge Eye Institute, Department of Ophthalmology, Visual and Anatomical Sciences at Wayne State University. She's also an assistant professor in the Department of Ophthalmology and Vision Sciences at the University of Toronto. Oh, so you're in two nations. That's pretty exciting. Dr. Yoganathan has been working cross-border for 12 years, currently in both Detroit, Michigan, and Windsor, Ontario. With regards to her education, Dr. Yoganathan was born and raised in Montreal, completed a Bachelor of Science in Physiology at McGill University, and obtained her medical degree at Albany Medical College in upstate New York. She then graduated from residency at North Shore Long Island Jewish in New York City. She completed her vitreoretinal fellowship at University of Toronto, and Dr. Yoganathan also graduated from the Royal College of Physicians Educators Certificate for Physician Leaders and obtained a Master's of Science in Health Research Methodology at McMaster University. So I will let you talk a little bit more about your background, Dr. Yoganathan, as we get started. Welcome, and thank you for joining us.
You're very welcome. Thanks for having me.
We're excited to have you today. We're also going to begin our conversation, since this is about sickle cell retinopathy. We wanted to give a little bit of background about sickle cell disease itself, which is a genetic condition. So bear with us for a moment as we have a video to share with you.
Hey there, I'm here to tell you about sickle cell disease, an illness that affects over 100,000 people right here in the United States and millions more around the world. The first thing you need to know is that you can't catch sickle cell. It's caused by a genetic change that is passed down from your parents. If a mom and dad both have that changed gene, then the child has a chance of being born with sickle cell disease. Now, let's talk about what sickle cell can do to your body. These are red blood cells. More specifically, these are healthy red blood cells. These little guys are going to carry oxygen all around your body to places that need it, like your heart, your brain, and your lungs. See how round these red blood cells are? That shape and the fact that they're super flexible allows them to move through the body without any holdups. That's good. People who live with sickle cell disease do have healthy round red blood cells, but they also have cells that look like this, a little different and not as round. See that? It kind of looks like a banana, or what they call sickle shape. So the big question is, why do some red blood cells sickle? It starts with something called hemoglobin. Hemoglobin is the part of the red blood cell that carries oxygen. People with sickle cell have a type of hemoglobin that doesn't carry oxygen as well. After sickled hemoglobin releases oxygen, it clumps together in a stiff rod inside the red blood cell. This causes the red blood cell to become sickled, or banana-shaped. That whole process is called polymerization and is what changes the shape of the red blood cell. Sickled red blood cells are very fragile. This causes them to break down more easily than healthy red blood cells. Picture a jelly donut exploding. Everything is released from the red blood cell, and the entire thing breaks apart. This is called hemolysis. When those sickled red blood cells break down, one of the things that is released is a substance called bilirubin. Too much bilirubin can cause the eyes and skin to turn yellow, which is called jaundice. Also, because the sickled cells break down, there are less and less red blood cells in the body to carry oxygen. When there are too few red blood cells carrying oxygen, it can lead to something called anemia, which can make people weak and tired. Also, those sickled cells are stiff and sticky and don't move freely. They can pile up and block blood flow inside your blood vessels. It's like a traffic jam and can keep the healthy red blood cells carrying oxygen from getting where they need to go. When those banana-shaped red blood cells get stuck in the tiny blood vessels, it can also cause a lot of pain. In the joints and bones, in the chest and stomach, it's called a pain crisis, or an even bigger word, vaso-occlusion. VOCs for short. A pain crisis can last a few hours. It can last days. And it can be so bad that a person with sickle cell may even need to go to the hospital. All of this, the red blood cells bursting, the low number of healthy cells, and the traffic jams in the blood vessels means that less oxygen is delivered to the body. And that can do a lot of damage to important parts of the body, like the bones, organs, and tissues. They all need oxygen to do their jobs and keep you feeling your best. So now you know what sickle cell is and what happens in the body when cells sickle. Sickling happens every day. The traffic jams, the lack of oxygen, they always cause damage even when there isn't any pain. That's why people living with sickle cell are warriors. Some of the strongest, most courageous people walking on planet Earth today. They want to live their best lives, and I'm here to cheer them on.
So with that, we will begin our conversation. And in a moment of transparency, I will say that I'm the mom of a sickle cell warrior. So we have a vested interest in sickle cell retinopathy and in ophthalmologists like Dr. Yoganathan. So again, thank you for joining us today. So following up on that video, let's start by talking a little bit about what causes sickle cell retinopathy.
Thank you again for having me today. Yeah, I'd love to talk about sickle cell retinopathy. Unfortunately, patients with sickle cell have this word that you mentioned in the video, vaso-occlusion. And what that means is that the vasculature, vaso, which is blood vessels, close. And when they close, there's not enough circulation that gets to the tissues. So in the body, that could present as pain. And in the retina, what happens is that those blood vessels no longer feed the tissue. When parts of the retina don't have proper circulation, the retina releases you can call it a chemical called vascular endothelial growth factor. And that makes abnormal blood vessels grow on the retina. That can lead to bleeding in the eye and ultimately can lead to a detachment of the retina. Thankfully, we have amazing screening tools where we can take wide field images of the retina with a camera called the Optos. We can use that same camera to perform something called an angiogram, where we can highlight the blood vessels and the circulation in the retina, which points exactly to where we need to treat. So thankfully, with a proper examination, annual screening, and advances in technology, we can really provide comprehensive care, eye care, that is, to the patients with sickle cell disease.
So is this retinopathy preventable at all?
I'm not sure if it's actually preventable, but it is quite screenable. So we can watch it at a very, very early age, catch it early, again, with proper screening. And so we can treat the areas that are going to be problematic early, and that will prevent hemorrhaging in the eye, and that will prevent a detachment. So from the patient point of view, they may never have to notice any problems with their vision or suffer any kind of complications of the eye with proper screening.
And how early should these screenings start for patients?
Oftentimes, I think it's never too early, but oftentimes the recommendation is about 10 years old.
Okay, so
But you can come in, sorry.
Oh, go ahead. No, continue.
For example, at the age of 10, you can come and pay a visit to an ophthalmologist or a retina specialist. And it's quite easy for us if we have those cameras, like we do at the Kresge Eye Institute. We have that wide field imaging camera. And so that can really take beautiful pictures of the edges of the retina where the disease is prominent. The disease is rarely prominent in the center of the retina. It affects the sides more.
So maybe explain to people, I'm sorry, I'll ask others if they have questions too. So maybe explain to people the importance of the type of eye professional that you need to see for screenings for this type of condition.
Sure. There's plenty of extremely competent, knowledgeable, and experienced optometrists and ophthalmologists. I personally am a retina surgeon, which means that I specialize in both medical and surgical retina. That's what I do all day long, regardless of what country I'm in. And so that's just my bread and butter to use these types of cameras and this type of screening and do this kind of laser.
Are there questions from anyone else?
I have a question.
Go ahead.
I guess my question would be, everybody that has sickle cell, do they have problems with their vision? And the reason why I'm asking is because I have pseudotumor cerebral, and so my vision was always good, and it happened all of a sudden. So how would a regular eye doctor, because my regular eye doctor didn't detect it, so how would you know to go and see a specialist?
So specifically, if we're speaking specifically about sickle cell patients, first you could learn what type of sickle cell you have. So depending on the genetics that you inherit, you could be what they call sickle cell SS or SC, like the letter C, or S-thal, like thalassemia. And the patients with SC genetic mutation have less body crises, like less effects in the body, but they have more retinopathy. So if you know that what your genotype is, that will put you sort of more alert and more aware that you definitely need to get your eye exams every year. And if you are SS, of course, you should still go for screening, but the chances of you having any retinopathy is less. In terms of how would you know if there's something wrong with the eye, if you waited until you had vision problems, meaning bleeding in your eye, it would likely be more at the later stages. So if you had floaters already, that are red floaters, meaning blood in the eye, that would be a later stage. So the way to prevent any of that is just to go for regular screening, where we can perform those pictures, which the regular pictures without the angiogram, they don't hurt. We're not sticking anything near your eye. We're just taking pictures of the eye. So we take pictures on 3-year-olds, 4-year-olds, not specifically for sickle cell, but the camera can accommodate very young children. To answer your question about pseudotumor cerebri, that can happen, yes, suddenly. You can have it without having any symptoms. So in our general screening, we typically don't screen for, we don't look for specifically pseudotumor cerebri. We do look for things like optic nerve problems, retina problems, cornea problems, lens problems. We look at each structure of the eye and look to see if everything looks healthy. So that's typically what the eye exam involves.
Okay. Are there other questions? Okay, so that leads me to a question about signs and symptoms. So you did say that if you're having some types of signs and symptoms, the disease, retinopathy may have progressed somewhat. So what are some of the early signs? Like, I don't know what a red floater is. So, I don't know what bleeding in the eye looks like.
The retina oftentimes doesn't have any signs. So you may be completely fine, but you may have disease in your retina. So you wouldn't know without a screening exam. Similarly, if you had diabetes, you would never know that there's retinopathy from diabetes unless you went for your annual screening, which is also recommended every year to go for a retina exam. All of that kind of retinopathy that we're talking about comes from the same place: lack of circulation that makes that chemical release, which causes abnormal blood vessels to grow. So that's why screening is so important for patients with sickle cell, and for what we're talking about, diabetes as well. You would never know if there's you would rarely know if there was retinopathy unless it had already progressed.
Are there stages to this progression?
Sure. So there's two broad categories, non-proliferative and proliferative. So non-proliferative means you can have just areas of bleeding, like superficial areas of bleeding. Those are called salmon patches. Sometimes those scar and leave behind little black scars in the retina. All of those things don't have any effect on vision, and they're off to the sides of the retina, which is more of the support structure. It rarely affects the center of the retina. So those are called non-proliferative. That's the category. The category that requires actual treatment, for example, with laser, would be one of the more advanced stages of what's called proliferative sickle retinopathy. So proliferative would start with the lack of circulation in the retina that I talked about earlier. You could have blood vessels that are trying to compensate. If there's no circulation in one part of the retina, the blood vessels may grow, and that's called anastomosis, and that could help provide extra blood flow in that area. That's called remodeling. That happens in the heart and other parts of the body as well. So that's stage 2. And then stage 3 out of 5 total. Stage 3 would be if the abnormal, that signals release and the abnormal blood vessels start to grow. And when the abnormal vessels start to grow, they carry a scaffolding tissue with it. So basically, the blood vessels grow and they carry some fibrous tissue with it. And that starts to pull traction on the retina. That's called stage 3. And that's called C-fanning, actually. I don't know if you've ever heard that word, but C-fan. So it looks like a C-fan where the blood vessels are coming and spreading towards you when you're looking at the retina. It's 3D, so we can see 3D when we're looking at the retina with our instrumentation, and the blood vessels are coming towards you. If those are not treated in time, then it would lead to stage 4, which would be hemorrhaging into the vitreous cavity, and then stage 5 would be if the retina detached because of all these abnormal blood vessels. So you have to go through a lot to get to a detachment. Most of the patients that I see, we catch it at a stage with our angiography technology, we catch it at a stage that we can treat it with laser. So what I do is I laser all the parts of the retina that don't have proper circulation. And then we probably need maybe 2 laser sessions per eye. And we do the laser in the clinic. You don't have to go to the operating room. You lean back in a chair, and the same way that we look at you with a light, the light comes with a laser. So it can be a little uncomfortable, but it takes not more than about 10 minutes or so. And then after you've completed your laser, you go home, go about your day normally. You don't have to take time off of work or anything like that. You come back for a visit about 2 to 3 months later. We repeat that angiography, which is a dye we inject in the vein. It goes to the eyes, and then we look and see, oh, did those C-fan blood vessels close? Did the blood clear? And if it did, then you don't need any more laser, and typically it stays stable. If you continue over years to have more blood vessel growth, C-fanning, then we just continue a little bit more laser. Most of the time, the laser stays at the edge of the retina, so it doesn't affect your vision too much. It's something that we diagnose, we see ourselves. Oftentimes, the patients only see it if they have a bleed in their eye.
This is fascinating. I find the body fascinating, especially the part about the C-fan. I'm picturing that and how it.
I know I should have brought show and tell photos
Right.
for you. I think you would find it fascinating. I mean, I'm very biased, but the retina is quite beautiful and really so interesting to look at, with the blood vessels and the nerve and all of these structures and how it came to be. It's to me, and to most retina specialists, it's quite beautiful to look at.
Wow. So it sounds like this progression could actually take some years to happen, or is it something that happens very rapidly once it starts?
Absolutely. It could take years.
Okay. All right. And well, aside from the treatment, I guess that's the only way this would be reversible then, is with treatment. And is that laser treatment the only treatment for retinopathy?
It's a good question. At the early stages, sometimes you can just observe. Sometimes the retina figures out how to fix itself. We watch it with those pictures carefully because we don't want it to progress too much. But definitely once it gets to a stage that deserves laser, we would either offer laser or injections in the eye. And injections may sound quite horrific to you and to most people, but injections are actually the most common procedure done by a retina specialist, all over the world. The injections have revolutionized in a great way the field of retina. So now there are amazing treatments for people with diabetes, with macular degeneration, high blood pressure, and, for example, sickle cell if they needed a quick treatment. So the injection works very quickly to close, remember the C-fan we're talking about, it will close those vessels right away. But the injections only last a month or two. So it's not a one and done deal. You have to continuously inject. And so the decision to inject is not an easy decision because we want to make sure that you don't inject too much, because the blood vessels could contract and the scaffolding could contract and it could lead to a retinal detachment. So we weigh the pros and cons of all of the treatment options very carefully. And so in my experience, the injections for sickle cell I use much less often than I do with the other diseases that I mentioned. The mainstay is typically laser.
Okay.
And this is a very different laser than, the laser that people go to correct their glasses. And, it's a common question. Oh, will I not need my glasses anymore after laser? The retina laser is very different.
Oh, interesting. So, okay. So is there pain that accompanies this? Let's say you're unaware, if you haven't been to your vision professional and you're unaware that you have this retinopathy and it's starting to progress a bit, is there any pain associated with the progression? If I looked at you in your eyes, would I, like you can see jaundice in people's eyes when they're jaundiced. Is there anything I'd be able to look at if I looked in, my child's eyes? Nothing I'd see at
Never.
all? Okay.
Nope. There's nothing that appears on the outside of the eye. So anything that you would see in the mirror is not something that affects the retina. So the retina is inside the eye. You can't access it. You can't see it unless you have something called an ophthalmoscope, where we look through your pupil, shine a light into the eye, and look at all of the back part of your eyeball, the inside back of your eyeball.
So again, that message for people to get their annual screenings for this is really critical. Talk a little bit about
just to answer your initial question, is it painful? No, it is not painful. You could have, again, not necessarily related to sickle cell, but if you had a completely detached retina, it would very rarely be painful. Retinas can detach and there's no symptoms other than blurry vision.
Oh, interesting. So that was going to be my question, talking a little bit about retinal detachment, because we hear about that with so many different types of retinopathy. So, is the end result of a detached retina, is that always blindness? Is it,
No.
what actually happens there?
No. So oftentimes, because the disease affects the side of the retina, the periphery of the retina, the detachment would start in the periphery. So it would have to progress and advance quite a bit for it to affect the center retina. We always advise and warn patients that in order to repair a retina, it can involve a lot of mechanical, physical things that we do to the retina. We have to, remove the traction from the retina, which may involve cutting the retina. We have to laser it down. We sometimes put a gas bubble in the eye or an oil bubble in the eye to help reattach the retina. So there's a lot of things that we have to do in order to reattach the retina, and that may leave you with worse vision than when you started with, even though the retina itself is only detached on the side. So sometimes you have to give a little to obtain a stable long-term treatment.
Well, that leads me down a tiny rabbit hole then. If your vision is going to end up worse, if you have your, retina worked on, what's the trade-off? What's the value then of having a detached retina taken care of?
So if you don't repair a detached retina, you will lose the entire vision and you could lose the eyeball.
Okay. And if you lose one eyeball, does that affect the other very often? Okay.
No. You would just want to get screened more thoroughly with your remaining eye.
Okay. So a quick question for caregivers and for patients. If you're going in for your annual screening and exam, what type of questions should you be asking? Because very often we go to the eye doctor, we let them do what they do. We let them give us the piece of paper, maybe with our new prescription on it, and we go about our merry way. But I think overall with healthcare, particularly for people who may not be as engaged in their healthcare as they could be, sometimes, there's a fear out of respect for physicians and people just don't ask questions. So are there questions that people can be asking of their eye care professional to help them have a better understanding of potential complications or things like that?
Yes, I think just understanding what it is that we have diagnosed in the eye. So for example, someone may have early sickle cell disease in the retina. So not the C fanning, but something like a salmon patch hemorrhage. A salmon patch hemorrhage refers to a term where, usually blood is red, but in patients that sickle, the blood appears pink in the retina. So sometimes we find little hemorrhages like that, which show signs of sickle cell disease, but not necessarily those that require treatment. Understanding how to make your follow-up appointment is very important. I tell all my patients to leave their current appointment with their scheduled follow-up appointment. So even if I say everything looks great, you don't need any treatment in your eye today, I will see you in 1 year. Make that 1 year appointment now, even if you don't know your schedule in a year. So that way you'll get a reminder prior to the date. And if you need to change it, at least it's on your radar. The problem is a lot, everybody is busy and everybody has 100 appointments sometimes per year. It's really hard to manage for both the patient and the parent or caregiver. And I'm completely sympathetic to that. Other people are suffering with much more disease, their pain crises or other complications of their child's disease. That's really hard to deal with. And the last thing they're thinking of is their eyes, because there's no problems. They go to school, they can see the board, they watch TV, they play video games, they read normally. So why would you go? So it's just a matter of making it part of your routine, whether you see X doctor, the dentist, for example, twice a year, however you remember to see the dentist. I would advise maybe putting an alarm in your phone, something to alert you to get that appointment, and make sure that you follow as much screening as possible.
Okay, this has been very enlightening. Do we have any other questions from anyone who's joined us today? Okay, if not, is there any information you'd want to leave us with? Any, top of mind messaging that people should walk away with from today's conversation?
I just think education is always the best key to prevention. So I would say, reach out to your local eye doctor, understand what it is that we're looking for, and ask us any questions that you want. I love showing patients their pictures of their eyes. I love, at Kresge, we have these very large monitors, so you can put their retinas on display and show them all the things that we're looking at, they can see. And so some patients, for example, with diabetes, they come in, they look at their own pictures and they know whether they're going to get a treatment or not. So the pictures are really easy to understand, and I love sharing that information. And maybe that will lead to a more understanding of the disease in general with the patients. And my sickle cell patients, I also show all of them their pictures and their angiogram, and they know why we're lasering and where we're lasering and what our goals are. And I think partnering with your doctor helps in your understanding, so that you feel comfortable and confident in what we're advising, what we're recommending.
Well, thank you. Again, this has been really enlightening today. I think I've learned a few things. So I appreciate you, Dr. Yoganathan, for taking time to talk with us today about sickle cell retinopathy.
I appreciate you inviting me, and best of luck to you and your little sickle cell warrior.
Thank you very much. Thanks everyone else for joining us as well. Thank you.
Have a great day.
Thank you for tuning in. The mission of the Greater Detroit Agency for the Blind and Visually Impaired is to provide services and support that help blind and visually impaired individuals live productive, independent lives with confidence and dignity. You can learn more about the agency by visiting our website at www.lifebeyondsight.org. That's Life Beyond Sight, as in SIGHT.org. You can also call us at 313-272-3900 or email information@gdabvi.org. That's GDABVI is in our initials.org.